The chairperson for this session is going to be Dr. T. Kumaran sir and Dr. P. Arulvarman sir. We welcome you to the dais. Dr. T. Kumaran sir is a retired professor and head of Department of Psychiatry, Madurai Medical College. He did his MBBS, DPM and MD in Madurai Medical College. Postgraduate teacher since 1998. He is a PG examiner in various medical universities. Indian Psychiatric Society Activities President, Indian Psychiatric Society Tamil Nadu Chapter 2021 and 2022. Dr. P. Arulvarman sir, MD, MBBS, has done his MBBS in Thanjavur Medical College and obtained MD Psychiatry from JIPMER. He is currently working as Associate Professor and heading the Department of Psychiatry in IGMC and RI Pondicherry. He is the author of Psychiatry Made Simple and contributed Psychiatry chapter of Target JIPMER. Both books help students to secure top ranks. He has published many original articles in index journals and part of Pondicherry Government Sector Psychiatry team serving the poor and needy. The session is yours, sir. Kindly introduce the speaker.
Good afternoon, everybody. Happy to be in the second postgraduate CME program organized by the Tamil Nadu chapter of Indian Psychiatric Society. It's a new venture. The first one happened in Pondicherry last year, and I'm happy it's vigorously pursued and the session is going on well. And coming to today's topic, the current presentation will be on formulating a convincing management for a plan for a long case. See, long case is the one which is a dread for all the postgraduates, not even only in psychiatry, in medical cases also. So you need not be afraid about long cases. See, this is going to be our day-to-day affair. Or once you become a professional, this habit or this practice has to be imbibed to your normal routine activity. Just like you carrying out a routine, this should come into as a casual thing for you, because you cannot differentiate between a long case and short case. What do you think about a short case may become a long case when you start examining or listening to the patient. Here in psychiatry, it's somewhat different. So I don't know how the organizers selected this. See, I take class for the undergraduates in the first clinical and second clinical only about history taking and this long case. See, I usually just make a comparison between a history taking and examination non-psychiatric medical case and a psychiatric case. So that will make it very clear that it is also, the psychiatry is also coming under the medical field. And regarding a long case, I am little confused about the topic, because formulating a convincing management for a long case means whether it is about examination of a long case or post-long case management after you are self coming to a conclusion. So that will be clarified by our erudite speaker, Dr. Vikas Menon, with whom I have been associated since 2007. He was a PG. He presented the paper in our TAN Psychon. He got the award. I was the judge. Then he was teaching faculty in a private college where I went as a university inspector. Then later he was my co-examiner in the prestigious JIPMER for MD Psychiatry. And with these few words, I present this mic to Dr. Arulvarman to introduce the speaker.
Thank you, sir. Thank you, one and all. As you know, as sir told, long case is the determining part. It is the most important part of your examination. If you do your long case properly, you are 99% you are pass. Leave alone a short case and all these things will be based on your long case performance. Regarding the speaker, Dr. Vikas Menon, who did a MBBS at JIPMER, right? Then MD, everything is in JIPMER only. He did a SR, then assistant, associate. Now he is currently the professor in the Department of Psychiatry. He is having a lot of publications under his kit, and no need to introduce him further. Just only one thing, one recent event I would like to share with you. Like that, recently, some 2 months back, there was a conference. I was actually chairing, and Dr. Vikas was the speaker. Same post-lunch session. There was only hardly few people 10 or 20, 15 people only in the hall, including chairpersons of, and speakers of other things. Online, just only 40 people. But once started, Vikas started, it was rose on to 100 people. So 100 participants in the online, and almost the hall became full. All are attentive. Such is the power of, charismatic power of Dr. Vikas Menon, so that you will be enjoying the most important topic. Over to Dr. Vikas Menon.
Thank you to respected chairpersons for the very kind introduction. And so this topic is given to me is formulating a convincing management plan for long case. At the outset, I would like to thank the organizers for giving me this opportunity also to be here. It's simply wonderful to be here and amidst all the galaxy of speakers. So I'll be speaking from the floor, and I hope to have some interaction as we go along. So as the chairperson Kumaran sir rightly said, there was some confusion in my mind also about what I should cover and what I should not cover, because the topic was also, so I had a word with the organizers, and after both of us came to some kind of a consensus that at the end of the session, what I intend to cover is how we can organize our management plan and communicate it effectively. So after the case has been taken, sir, how to organize the management plan and communicate it effectively. And I'll be giving one or two case vignettes at the end where what all steps we are discussing in the formulation of a management plan, how we can apply it to common cases like acute bipolar mania or acute schizophrenia, so that our understanding is enhanced. And then along the way, at various points, we'll also learn some tips to answer important exam related questions, because a lot of how you present the management plan is about how you lead examiners to your area of strength, and how you can actually open the avenue for further questions. So we'll discuss a bit about that also. What this presentation will not cover, I will not be talking about the principles of writing a diagnostic formulation, because that's an entire topic in itself and there's a lot of things to discuss about that. Provide a comprehensive overview of clinical features of acute bipolar mania, schizophrenia when we are discussing the case vignettes. That's not really my objective, and I've kept the case vignettes very simple, because sometimes when you're discussing principles of writing a management plan, it's always easier to communicate that with simple cases rather than making it very complex. So that will perhaps be easy for you to understand and then apply for complex cases also. I will not be discussing anything about first, second, third line treatment options. And why I'll not be discussing about that also will be clear as we go along with the session. So I hope this gives an outline of what is intended to be clarified. A small request to the organizers is please give me a warning bell when I have 5 minutes left. 5 minutes left. Okay. So I think, as the chairpersons have said, all of us at various points of time, whether we communicate explicitly or not, we are all formulating management plans mentally for all patients we are seeing. We do it implicitly. In the exam, we do it explicitly. So I think you are all familiar with these three terms for the management plan, isn't it? The locus, the focus, and the modus. But how are we going to structure the information under these three headings? So locus means obviously where you are going to treat, what is the setting, isn't it? So we'll see each of these in some detail. The focus is the goals of treatment depending on what phase of the clinical cycle the patient is in. So there are various phases of treatment. Which phase the patient is currently in, it's based on that. The focus of treatment will vary. And then as far as the modus of treatment is concerned, you have various components like assessment and monitoring. That's obviously the first thing that's got to come when you're talking about the main management plan. Then the investigations, pharmacotherapy, psychosocial interventions. Not really, psychosocial therapies may be a better word than psychotherapy. So psychosocial interventions and somatic treatments and long-term management. So the idea is once you have this structure in place, then it becomes a little simpler to populate these headings and you are not likely to miss anything major. So in locus of management, obviously the most important decision that you're going to take and communicate to the examiner is whether you're going to manage the patient as an inpatient or outpatient. This decision is based on considerations such as the severity of illness, the extent of psychopathology, the current functioning of the individual, the level of support needs that the patient has. All this is going to factor in when you're making this decision. So, see, at various points of time when we are dealing with a patient, we do capacity assessment, but that's particularly important when you are trying to admit the patient, because whether you're going to admit under section 86 or section 89 is going to be dependent on whether whether the patient is capacitous or not. So, you have to tell that you will do capacity assessment. And here you see why it's important to give these kind of terms then and there, because immediately the next question is, okay, doctor, what are going to be the different elements of capacity assessment? So this is what I said. You keep attracting the examiner to your areas of strength. So you tell that I will do a capacity assessment and be ready with what all elements are there in a capacity assessment. And then based on that, you will say under what section of MHCA you are going to admit. Most of the time the decisions are between section 86 and section 89, but also there are other sections like, as you know, section 94, then other sections are also important. So under which section you're going to admit, that you have to mention. And if you are admitting, then obviously the indication for admission is also, you have to mention it in your initial part of the management plan. So the usual indications for admission are risk of harm to self or others, inability to take care of oneself to such an extent that you are at risk of risk of harm to self or others. These are mentioned in section 89, that is supported admission. These are the indications. There could be other indications for admission also, like acute aggression, excitement, also which broadly fits into one of these parameters. So what the message here is, you not only mention that you are going to admit the patient, under which section you are going to admit, and what is the indication for admission also you mention. Then coming to the focus of management, this depends on what phase of the clinical stage or cycle the patient is in. So suppose you are talking about the acute phase. What is the goal of the acute phase of treatment, say for bipolar mania? It is to induce a rapid response and reduce risk of harm to self or others, which formed the basis of your admission, isn't it? It was for risk of harm to self or that you admitted. So the major focus of management in the acute phase is always the reason for admission. Remember, the acute phase ends with remission. Acute phase ends with clinical remission. Then you have the stabilization or the continuation phase, where the goals are, okay, you have brought the patient into clinical remission, but now the goal in this phase is to sustain the symptom control. So this is important to mention. Depending on which phase your patient is in, you will have to frame the focus of treatment accordingly. And it is in this phase that you may want to consider adding psychosocial interventions, because the patient was not ready for it during the acute phase, or if you have started, you want to strengthen those psychosocial interventions. And then the maintenance phase. Maintenance phase, always the most important goal that you have to tell during the maintenance phase is, this word has to come, relapse prevention. So in relapse prevention, as we will be discussing, we'll look at modifiable risk factors for relapse. And you also want to focus on some things like rehabilitation, marriage, pregnancy, vocational rehabilitation, marriage, pregnancy. All these things also become a focus during the maintenance phase of the treatment. Then coming to the third phase, that is we finished locus and focus, so then what is the modus? So here, as we have these headings to populate, that is assessment, investigations, pharmacotherapy, psychosocial interventions, and somatic treatments. So we'll go through each of those. In assessment, which is always the first thing that you have to tell in your main, once you finish the locus, then what is the goal of management, once you tell, first thing you have to tell is, I will explore or I will clarify history. Here, all those gaps in the history that you could not take in the first sitting, it will not be possible for you to cover within 145 minutes or 1 hour what is allotted to you in the long case for the exam. It will not be possible for you to cover everything. That's okay, that's understood. But it's important that this is where you bring out those gaps and tell the examiner that I have not had enough information or I have not had enough informants to cover this. So therefore, I will clarify these gaps in my history. What could those be? Usual things which remain as gaps are pre-morbid personality, or things like substance use histories, past episodes you are not very well delineated. You might have focused more on the current episode. So the past episodes, previous response to treatment, all these things will come in here. It's really important to make a note of what all you could. So this, how do you populate is, as you're taking the history, you should be noting down where all you had the gaps, so that at the end you can bring all these points. mention additional sources of information that you would like to tap into. This may be additional family members, more medical records, previous treatment records, or any previous clinician who has treated the patient. So all this could be additional sources of information that you want to tap into. Risk of suicide or violence. See, remember, risk of harm to self or others is often one important indication for admission. So suicide risk assessment and formulation or risk of violence assessment, there are structured, there are manuals available, there are articles, plenty of art literature available on how to perform suicide risk or violence risk assessment. It's beyond the scope of this lecture to discuss it, but you have to mention it here, and you get a lot of credit for doing it. You get a lot of credit for telling this that you will do, and immediately the next question will be, how do you do a suicide risk assessment? What are the various elements that go into it? How do you do a suicide risk formulation? So you see how you are drawing the examiner to your areas of strength. Baseline rating scales. So these could be to measure the severity of psychopathology at baseline and to obtain some baseline measure against which you will constantly monitor the symptom improvement. And remember, often you may need more than one rating scale. For example, if a patient is having mixed affective features, you may require both YMRS and the HAM-D at baseline to rate the progression, clinical response to treatment. And you also need to tell how frequently you will re-administer these scales. So for example, you are administering them today, how frequently would you like to re-administer? Not just the rating scales, but for example, the risk assessment for suicide, Suppose the patient is at imminent risk of suicide, the suicide risk assessment will have to be repeated every 48 to 72 hours. So how frequently you are planning to repeat these assessments? If they are at a variable frequency for differing instruments, you need to mention it. So you get a lot of credit for being very thorough with your management plan. So immediately once you put like this, the examiner thinks, okay, here is a person who is very organized, who is very meticulous, who has looked into all possible aspects, and you get a lot of credit for that. Coming to investigations, a lot of examiners don't like using the word baseline. So better you can avoid that. Although I have put it here, it's a message that you can try and avoid that and just say what you're going to test. Like say, for example, you will do complete blood count. You will do renal function test, liver function test. Now, you will also come across one term when you're reading literature called blood biochemistry panel or blood metabolic panel. It's better to avoid these terms because there's little consensus on what all goes into a blood biochemical panel. For example, if you see, for the purpose of this presentation, I reviewed some literature and I found a lot of disagreements between the sites. For example, one of the NIH sites said 7 to 25 tests can be accommodated in what we call as a blood biochemical panel. So it's unlikely that, any two of us will agree on what all so it's better that you say what all tests you're going to do rather than using fancy names. So you might want to do renal function test, liver function test. The message important that you have to remember is whatever test you are saying, you must have a justification for that. So why do we want to do liver function test? Because most of the psychotropics are metabolized by the liver. You want to know whether the liver is okay. Otherwise, you want to reduce the effective dosage that you may be giving, including the starting dose and things like that. So FBS, FLP. Some guidelines also mention thyroid function test and a blood biochemistry panel. So that is what you have to tell the tests that you have to do. ECG, urine toxicology, especially for people with suspected substance or drug abuse. ECG, chest X-ray may also be important in some situations. For example, if you're planning to start an antipsychotic for a patient with delirium, you know that such people are at high risk for conduction disturbances. So you want to rule out a baseline QT prolongation by doing the ECG. So all this become important in different cases according to the nature of the symptoms. Then some of the indicated investigations like brain imaging, EEG to rule out organicity, serology for HIV, HBs, AG in atypical presentations, some of the specific pre-drug investigations like pre-lithium or pre-valproate investigations, all this as indicated for a case, not in every case. And then don't forget psychological testing if it is required. For example, in a case of dissociative disorders, you know that psychological testing is an important part of investigation. For example, if you are not able to bring out a stressor clinically in a face-to-face interview, you might want to take help of psychological testing to find out the underlying stressor. And it can also be good for identifying treatment targets. Once you identify the stressor, then only you have something concrete to manage, for example, in a dissociative disorder. So psychological testing can have both diagnostic and therapeutic implications. You mention it if it is warranted in your case. Some important points here while telling investigations in the exams. Tell only required investigations. We already told you that there must be a justification for every investigation that you choose. Just because it's available in your hospital, or it looks a little fancy, or the patient is affordable, that's a sure shot way of rubbing the examiner the wrong way, that you are going to tell that you will do this and that. And what is the frequency of monitoring? For example, how frequently you will repeat the fasting lipid profile, how frequently you will monitor the weight gain. This is very important to know, and also be ready with the information. I think once you tell a test, maybe automatically the next question that will come is how frequently you will do the FBS or the FLP. So there are very clear guidelines for antipsychotic or other medication monitoring guidelines are there. Please be cognizant of that. Special investigations, like you may want to do a vitamin D estimation, for example, in people with treatment-resistant depression. You may want to do an antibody panel for somebody with a suspected NMD encephalitis. So these are some special investigations which you might want to consider depending on every case presentation. Okay, now moving to pharmacotherapy. So in pharmacotherapy, the question is obviously what medication you want to start. You have to mention it. I'll start drug A or drug B. And what is the starting dose and what is the target dose. Remember, there are many drugs in psychiatry that require titration, like clozapine, quetiapine. For quetiapine, for example, the target dose is often 300 to 600, but we cannot directly start with 300, no? So these are drugs which require titration. There are drugs which do not require titration in psychiatry, like escitalopram, okay. Anything else? Sodium valproate. Sodium valproate may require titration, isn't it? Because unless you're giving the loading dose, you might want to up-titrate valproate. Acamprosate doesn't require titration. Endoxifen doesn't require titration. Duloxetine doesn't require titration. Even for that matter, lithium does not require titration actually, unless you're giving to some people where you're suspecting organicity. So there are various drugs where you don't require titration in psychiatry. Some drugs where you require. Wherever you require titration, remember to mention the starting dose and remember to mention your target dose. Are you all able to appreciate that target doses of the drugs may differ according to the age, according to the number of relapses that the patient has had? For a first episode, it's different. For a chronic psychosis, it's different. Are you all able to appreciate that? Very good. Where do you get the target doses of drugs? In prescribers' guides, like Maudsley prescribing guidelines or other prescribers' guide, you can get these information. So please be aware of these information. And then whether you want to give it in once daily or divided doses. For example, you all know when you have to give lithium divided doses versus lithium once daily, isn't it? So there are situations where you have to give once daily. There are situations where you have to give in divided doses. So be aware of that. Whatever you are going to do, please tell that. Depending on the drug, depending on the patient. Don't forget to tell that you will educate the patient about adverse effects. Once you give this teaser again, you are leading the examiner to the question about what are the adverse effects that you want to educate the patient about. And then you are on strong grounds. Start low, go slow, that is all based on the starting dose, target dose concept. You have to know the effective doses of medications. We discussed that. You will get this information in your prescriber's guide. Avoid irrational polypharmacy. For example, you're telling that you will, whenever you're starting antipsychotics, will you also start anticholinergics side by side? Not always, isn't it? Not always. So, irrational polypharmacy. If you have a justification for choosing two antidepressants combination therapy together, go ahead and tell, but otherwise avoid irrational polypharmacy. Justify your choice of medications, why you are going to start, or at least be ready with the answers. If they ask you why you want, it's a common question and it's a bread and butter question. You want to start risperidone. Why do you want to start risperidone? Why not olanzapine, or why not other drugs? Why do you want to start escitalopram? Why not sertraline? It's just, the examiners, maybe they're having a little fun with you, but that's how it is. They might like to ask you those questions. So be ready with those answers. Be ready with adverse effects, but don't tell. See, don't tell unnecessary information in your management plan, because if you rattle off all the adverse effects and if you rattle off all what you will do once the first line of treatment has failed, examiner will go into very difficult areas about which neither they are sure nor you are sure. So, see, remember, they have come all the way to ask you some questions. They have to ask you. So if you don't give them any opportunity to ask and you keep rattling off all the information that you know, then you might be in trouble. So, Don't just be ready with adverse effects, but don't tell. Okay. Know the cost of selected medications. The other day, I had one of my residents who will tell that he will prescribe endoxifen. It costs, you know how much? It costs 100 rupees per tablet. Even I will think twice before I buy endoxifen. So, you get often fascinated by reading a lot, and people who are typically in the final year, just before exam, your knowledge peaks because you are reading a lot, Your knowledge might be actually more than what I or someone else knows because you're all reading so much. We're not reading as much as you people. So, but you must be very circumspect and very conservative in your choice, Tell only those that you have been doing in your institution for the last 3-4 years, whatever is your period of training. No funny tricks, no new agents on the day of the exam, nothing, okay? Be conservative. Do not tell second or third line management options. Again, for the same reason that you want to leave some room for examiner to ask questions about which you have some know-how. How to select medications, course of illness, obviously that is important when you're selecting for somebody with, the MDE course, you will choose lithium. For DME course, you will choose valproate, all that. I don't have to tell that. For past response, non-response, that's a no-brainer. That's the major reason why we select medications. Past adherence, the cost, I just now mentioned about endoxifen example, the dosing schedule, the side effects, drug interactions, comorbidity, the demographic factors of the patient, for example, age, gender, educational status, distance from hospital, all this could be factors influencing your choice of medications. And feasibility of monitoring, for example, you want to start lithium, but the patient is not in a position to come for the frequent serum estimation. So you may want to consider other options. So these are just some information for you. If you are asked how to select information, these are all, how to select medications, these are all some of the factors that we need to keep in mind. Coming to psychosocial treatments, obviously psychoeducation is something that all of you are going to tell. When you tell that you will give psychoeducation, you can expect questions like, what are the components of psychoeducation that will be given? How frequently you will give, what is the procedure involved? So be ready with the follow-up questions. Apart from psychoeducation, some disorder or issue specific therapies depending on your case, like say for example, you can say that I will give motivational interviewing for poor adherence. Use technical terms. Don't be afraid to use technical terms when you're doing this part of the management plan, because again you're leading the examiner to the next question. Okay, doctor, how will you do motivational interviewing? What is the first question you will ask? How many sessions will you take? So many things, so many questions are there about which you can be prepared here. So these are better areas to get than Freud's dynamic theories. MET for substance use, ERP for OCD. Any day questions on these are better, no? Family therapy for expressed emotions. I will give interpersonal social rhythm therapy for bipolar disorder. Okay, you tell me what are how you will do IPSRT, what are the 2 or 3 components of IPSRT, like that. So one common mistake that often is made is, you will give psychoeducation to patient and family, you will say, but if the patient is in acute mania, the patient is not really in a position to receive psychoeducation. So whether you will give it to the patient or family first, that is something that you have to also mention in your management plan. What all you will cover in psychoeducation. And as I said, use technical terms and be ready for follow-up questions. And a very important part of your management plan is don't miss out saying 1 or 2 statements at least about long-term management, that you will look at modifiable risk factors. It might include things like substance use or poor adherence. When I show the case we needs, it will become clear. So at least 1 or 2, even though your focus is mostly on immediate management when you are presenting in the exams, you also get a lot of credit for saying that you are going to look into some of the issues which might be potential triggers for relapse in follow-up. There are somatic treatments like ECT, RTMS, TDCS. Not all institutes have them, but if you have been trained in an institute where you have had exposure to these therapies, you can mention these, provided it's most important for you to know is when to use each of these. For example, I think all these indications. So whatever modality you are telling, you should be ready with the indications for use of these treatment modalities. And at the end of the management plan, don't forget to mention at least 1 or 2 lines about the prognostication of the case. That means what are the good prognostic factors, what are the bad prognostic factors, and also that you will educate the family if they want to know about these prognostic factors. So that would complete the management plan. So let's see how we can apply that to 1 or 2 cases. Okay. So I will just take a minute to read out this case for you. A 24-year-old single unemployed male is brought to the emergency department with injuries on his hand sustained after a brawl in a bar. On inquiry, his family members reported that he was experiencing altered behavior for last 2 weeks. He would be very irritable, talk incessantly and often irrelevantly, boast about himself and indulge in excessive drinking and reckless behaviors like drunken driving repeatedly during the episode. He appeared fresh and active during the day, though he would sleep very little compared to earlier. He had marked socio-occupational impairment and his BMI is 32.5. He had a similar episode at the age of 18 for which he required hospitalization for 2 weeks. No treatment records are available for this episode, but the family remembers that the symptom profile was broadly similar to the current episode, with risk of harm to self and others stemming from extreme aggression or excitement, and patient also had difficulty in adhering to treatment recommendations. The episode was short-lasting. There is a positive family history of bipolar disorder in his maternal aunt, who is stable currently on lithium. So there's some family history of response to lithium. And he has irregular sleep-wake habits, particularly after social gatherings where he tends to get inebriated, though there is no dysfunction due to this. So, what is your diagnosis? Very good. So, there is no doubt about the diagnosis. How will you prepare the management plan for when you are presenting? This is a bread and butter case, no? Is usually asked in the exam. So, you start with the same how we went. So the diagnosis is, according to DSM-5, bipolar 1 disorder, current episode manic with other specifiers as appropriate. And with obesity, you all know that the multi-axial system is no longer relevant in DSM-5. In ICD-11, it is bipolar type 1 disorder, current episode manic with psychotic symptoms. According to ICD-10, many of you may still be following ICD-10, but it's good to be conversant with ICD-11 because as of January 2022, ICD-11 has been officially adopted worldwide. But better for you to be familiar. According to ICD-10, what will be the diagnosis? Current episode manic with psychotic symptoms. Okay. So now you will want to obviously admit this case, isn't it? You will want to admit this case. Reason is risk of harm to self or others. Very good. The focus is to induce rapid response, to control the risk of harm to self or others. Okay. And I already told you acute phase ends with remission. Okay. Now in assessment, because I have not provided enough history for you, you might want to assess for ADS. Okay. You can also mention other gaps. I'm just giving you some examples here. Okay. Can I mention other things that you are not clear? You might want to assess for risk of violence or aggression because that is one of the major reasons for admission. So you're going to tell that here, isn't it? Investigations. Apart from all these, I also think that because the patient sustained an injury after a brawl in a bar, maybe there was some head injury or something, so possible of there may be some indication for doing the imaging. So that's a special investigation in this case. Maybe not every case needs to have this. Rating scales, I think YMRS alone is sufficient. Do you agree with me? YMRS alone should be sufficient here. Pharmacotherapy, I will initiate treatment with lithium. It's the second episode. I will initiate treatment with lithium at 900 milligram per day, plus risperidone at 2 milligram per day, plus lorazepam at 4 milligram per day in divided doses. Okay? But what is I also told you in pharmacotherapy, you have to tell not only the starting dose, but also the target dose. So my target is I will aim for serum lithium levels of 0.8 to 1.2 milliequivalents, risperidone 3 to 6 milligram per day, and lorazepam 4 to 6 milligram per day in divided doses. I will educate and monitor for adverse effects like weight gain and YMRS ratings on a weekly basis. Alright? So coming to psychosocial treatments, I will give psychoeducation to the family right now. The patient is not in a position to receive psychoeducation, so I will give psychoeducation to the family to help understand the illness and support the patient better. So I am also throwing terms at the examiner for asking me more questions. Okay? Once patient improves, I will give psychoeducation to the patient. I will consider interventions for improving medication adherence. Remember, in the case history, there was a clear history of having difficulty in adhering to treatment recommendations. So I have not forgotten that. I have brought that into my management plan. I will consider interventions for improving medication adherence such as CBT or motivational interviewing. Again, I am throwing leads. Okay? And I told you always mention 1 or 2 statements about long-term management. So in the long term, I will look at modifiable risk factors such as X, Y, whatever you have identified, and provide the necessary education and treatment for the same. Remember, the patient's BMI was that is class 1 obesity. Okay. So I will advise healthy life. Don't forget, see, you get a lot of credit for doing that. All these small things, it tells the examiner how thorough you have been, how meticulous you have been, you have not forgotten these things, and you will get credit for that. So I will advise healthy lifestyle measures and dietary modification. These are not very big suggestions or rocket science, but you are piecing together everything and you get credit for that. Prognostic factors, in this case, what are the good prognostic factors? All the episodes were of shorter duration. The previous episode was a short duration episode. That's what they said. Absence of psychotic symptoms. These are some good prognostic factors. Poor prognostic factors? Family history, young age of onset, isn't it? Young age of onset, poor treatment adherence, possible substance use. So these are all some poor prognostic factors. So be ready with 2 or 3 good and bad prognostic factors in this case, and that would complete the case. Okay. One more case. Do I have 5 minutes? Yeah, another 5 minutes I'll wind up. So a 25-year-old female employed in a call center was brought with acute onset complaints of restlessness, irritability and incident of violent attack on her mother just before the arrival to healthcare facility. Upon inquiry, predominant symptoms were suspicious behavior, delusions, auditory hallucinations, and these symptoms were present for 4 months. In response to the voices, she had attempted to end her life once about a week ago by poisoning, and insomnia, daytime anxiety were prominent. Pre-morbid personality was well adjusted. No previous episodes. Mother, who had a history of schizophrenia, died by suicide when she was age 12. Currently, she is cared for by her father, who reports that she was taken to multiple hospitals, but she would not comply with treatment recommendations and had to be given medicines surreptitiously. No medical comorbidities, but she reports a smoking habit which has intensified since her symptoms started, because it gives her relief from the voices. As a result of her symptoms, her employer has terminated her. What is the diagnosis here? Yes, according to ICD-10 it will be paranoid schizophrenia. According to ICD-11 also it will be schizophrenia. According to DSM-5, the duration is not sufficient to call it schizophrenia because it's only 4 months. So you will call it a schizophreniform disorder. Okay. I think this much is clear. Okay. Now, again you want to admit the case, isn't it? There is a risk of harm to self also. The focus is, I think we all know this. So history, you might want to assess for NDS. There is a smoking habit which has intensified recently, so you want to check for NDS. You want to do a suicide risk assessment and formulation, because about a week ago she has attempted to end her life by poisoning. Investigations, I think the whatever we are usually advising will do. I don't see any special reason for any special investigation in this case. Rating scales, positive and negative syndrome scale should be enough. I will initiate treatment with A at B milligram per day plus C at D milligram per day. Okay. And my target dose is so and so. I will discuss with the family about option of long-acting injectables because of poor adherence. So nowadays there is a trend towards introducing LAIs much earlier in the treatment plan, rather than waiting for the patient to have multiple relapses. By that time there has been a lot of neuroprogression, a lot of neuroplasticity changes in the brain, which may not be reversible. So you want to really intervene when there is maximum chance of good response and good outcomes. I will educate and monitor for adverse effects of PANSS ratings. I'll give psychoeducation to the family, followed by psychoeducation to the patient, and offer relaxation therapies. Why relaxation therapy? Because daytime anxiety was prominent, insomnia was prominent. So you can see how all those little things you're bringing here into the management plan. I'll consider interventions for improving medication adherence. And in the stabilization phase, I'll do motivational interviewing for nicotine use and offer NRTs, that is if you have proceeded with the NDS diagnosis. And if the patient doesn't agree for LAIs, at least in the maintenance option, I'll keep that option open. In the maintenance phase, I'll keep that option of LAIs open. I'll also support the patient and family in efforts to secure alternate employment through vocational approaches. Good prognostic factors in this case? Good, stable pre-morbid personality, more of positive symptoms in the presentation. Poor prognostic factors? Family history of schizophrenia, poor treatment adherence, substance use, all this could be poor prognostic factors. These are my last couple of slides. So there is a mnemonic what examiners look for, that's called ABCDEF. It's again nothing very complicated. It's all the amount of analysis you do in your history and the amount of anticipation that you give to anticipated issues like medication adherence. They always, examiners look for basics. They don't want any hi-fi stuff like second or third line management options. If you can tell the first line management options clearly, concisely, that's more than enough. clarity, coherence, like a story, you build up your, your HOPI and your management plan. Whether you are able to define all the therapies that you have told, like MI, CBT, ERP, delineation of the differential diagnosis, whether you have done a thorough evaluation and examination, and whether you have formulated the case well. These are some important things that examiners look for. So take home messages: follow a systematic structure in formulating a management plan. Be ready with justification for every word that you say in your management plan. Expect questions based on what you have said. Do not miss out specific issues like treatment adherence, substance use that you have yourself identified. Otherwise, you are not getting the credit for what you have identified. Say what you have been following and doing in your institution. So once I went for an exam, one of the candidates said that he will apply Leibovitz social anxiety scale for social anxiety. Actually, I also didn't know what that scale was. So maybe it's there in literature. Couldn't defend when he was asked. So that's a problem. You don't need to tell that. You can apply normal Hamilton anxiety scale. That also is good enough for any anxiety disorder. So what you have been saying and doing, that whatever you have been following, just stick to that. See, this is very important because it's a very big temptation for us to tell new things, because we're very excited and our adrenaline surge takes over on the day of the exam. It's also important to know what not to say and how much to say. That's why I said you don't tell all the adverse effects, you don't tell this and that, and then leave very little room for examiner to ask questions. So that's why I always believe, management plan is plenty of science, but a lot of art also. Finally, when you are not sure about any answer when you are asked, there's no loss of dignity in saying you don't know, rather than saying some guesswork, And remember, on the other side is somebody who has little more experience than you. Always look at the facial expression of the examiner, Examiners are not very good actors, so they cannot conceal their emotions. So they will actually give away the expression, so you know whether you are in trouble or not. But unless you are autistic, you should be able to recognize that. Follow clues given by the examiners. They are actually sitting there to help you. Most of the time, they are not coming there to fail you. They are coming to help you. But your tunnel vision or that adrenaline surge is not allowing you to. So be aware, follow the clues that they are trying to give you, and be flexible. Suppose, they are asking you whether this is the right approach or this could be also considered. No, I will not consider that at all. I will not even think of that. So be flexible in your plan, okay? I will acknowledge inputs given by Professor Sandeep Grover, Dr. Shahul Amin, and Professor Samir, all three people whom I work very closely with, for content as well as structure suggestions during this presentation, and thank you very much for your attention.
Thank you very much, Dr. Vikas. Very excellent presentation. And before going to the question sessions, I give you a hint. Some of you might have Dr. Vikas as examiner. Please follow his advice. So it's a real thing that may happen in 2 or 3 months. So I have been to the exams since 2010 for about 14 or 15 years, and I have been assisting as skilled assistant. Usually our students have good knowledge and they have formulated a plan, but they don't know how to present it. See, as he said rightly in the final few words, that every institution carries a certain pattern or a protocol. For example, NIMHANS, when we were students and when I was working as assistant professor, NIMHANS had a separate history-taking proforma, and IMH Chennai had a proforma. And if we go to the Kerala people will have a separate proforma. So ours will be totally different from all the three. But it is your flexibility, just he pointed out. You have to be aware about what the examiner is asking. Everything is common to all the protocols. Everything is common. Everything has to be followed. But it may be in the earlier stage or in the middle part of the presentation, there may be something in your present. For example, when I went as examiner first time and in the private colleges, when I heard about this plan of long case management, I was surprised. They will continuously telling, they will be going on as if there is a logoria. They will going on telling about, and they may miss something. So I will have an idea that they have been tipped by the skilled assistant. They will tell the brand name of the drug. So that you should avoid definitely. For example, if you want to start an antipsychotic, you have diagnosed as a psychosis. In this case, as such, in the first and second case, I am going to start a antipsychotic, means you have to tell, I will go with the conventional antipsychotic or the available atypicals are to avoid complications. Among the atypicals, we are using, there are a lot of atypicals, we are using risperidone and is time tested. It has been found to be effective in a lot of trials, and we have good, solid scientific evidence that it controls the psychosis early stages. You have to present with that. He said about titration of doses. So that all comes in the next aspect. So you have to be very watchful. First of all, you have to be very calm, quiet, and you have to think and answer. See, I get hints from the presenter only with the long case presentation. I will even never allow them to go to the MSc or the other things. So with that we can easily get questions. So I just discuss the whole case with their presentation only. I will not go into the scientific aspects or highly advanced scientific material, because they will learn by rote memory or they would have written the exam. So it is the clinical part and your discussion that matters more, which was very clearly and very precisely explained by our Dr. Vikas. And these 3 points you can take it as a hint: locus, focus and modus. That finishes everything. So that just like our medical education teaching, following our protocol, this cognition, cognition and affect, all this, you can follow this. This will give you a help. You will not forget. First of all, no, most of the people will never tell that I will manage this patient as inpatient. They will just say, I will give a risperidone or antipsychotic. Where? We will ask, whether in the market or in their home. So then they will realize. So you have to be very clear. This sort of tips or mnemonics will help you very much. With this, I hand over the session to Arul Varman for questions.
Okay. So as Dr. Kumar sir said, we should be very cool and calm. Okay, that's what important. If you are not very calm, if you have performance anxiety, you can do breathing exercise before presenting the long case. That's what we did, myself and Vikas used to do, not propranolol and that, right? Said. Before going to the questions, I want to ask one question to the audience. Okay, Dr. Vikas Menon told almost all the drugs should be started low and go slow. Can you consider any condition and class of drug where we give a higher dose? The reverse is true. Then we can go for MCQ, sir. Then you can discuss with anything regarding to the doubts and all with Dr. Vikas Menon in the deep time. Okay, thank you.
I think you wanted me to give them instruction to. The organizers want you to raise your hand, if you know.
Okay, please note it. Note here. So you will get some prize, no, Doctor Sir? Paneer sir, yes, sir. Raise your hand first. Yeah.
You have to speak into the mic.
Option A.
Yeah, I cannot see the question actually.
The first part of assessment.
The answer.
Because
Yeah.
Here.
Acha, okay. Okay. Congratulations.
Now we request the chairpersons to honor the speaker, Dr. Vikas Menon. Now I request Dr. Sabrin Sanjeev Rose to honor Dr. Kumanan. And I request Dr. Preeti to honor Dr. Arul Varman.
Dr. Shamni, Dr. Abita and Dr. Shanmugapriya.